I'm going to be sharing my screen with you guys. I'm going to talk to you briefly about how case-based instruction works in the Bloom's taxonomy and educational theory. And so we're going to talk about it briefly, and hopefully you guys will start to see how we have developed this case, and you guys, how we've developed the program over the years. Starting in 2012, we started integrating iPads into our classroom. And every student was issued an iPad, and this was really initially to start doing things like data tracking. That was kind of our goal, and also to be able to do electronic charting. And as the program developed and students started using different things, we started getting different ways to use the iPad, and one of the things that came up was RealDX. And so in 2014, we were first introduced to this program, and we started integrating it into our curriculum. So that's a little bit of our history and how we ended up with RealDX. I'm going to talk to you guys about how case-based instruction actually supports educational goals and what we are doing in EMS education. Bloom's taxonomy is something that may be review for educators. We probably have a lot of educators on here who have a lot of experience, but we probably have educators who have almost no experience. So many of us came straight from the field from EMS, and we were told go teach this class, but we didn't have the educational background to be able to do that. And so we learned lessons the hard way. And so hopefully this will introduce you and kind of offset some of those lessons. Bloom's taxonomy is an educational theory that was first introduced by Benjamin Bloom and David Crothwell in 1956. It's had many iterations since then, but it has been stayed tried and true in education. And what it is, it's a cognitive learning framework. So if you think about remember as a way to, as a baseline of education, beginning education, and then create as expertise, you move up the triangle as you stay in EMS and as you teach and as you learn. And so these different learning planes are what we are trying to achieve in our educational EMS education. So consequently, each of these learning planes have verbs associated with them. So when you guys are writing learning objectives and you're trying to figure out what do I want the student to achieve out of this lesson, you would go to say, oh, I want them to be able to analyze and evaluate. Then you would use verbs from those learning planes in order to create your learning objectives. And if you just Google Bloom's taxonomy verbs, you'll come up with a billion options for you to choose from. So getting into this a little bit, if you at the remember phase, this is recalling basic facts. And then the next phase is understanding phase. It explains ideas and concepts behind the basic facts. So we do this. This is a good chunk of what we do in EMS education and EMS theory courses. So most of your basic facts will be introduced in theory, but you also do have some basic things that are introduced in labs. So for example, you're teaching them how to take a blood pressure. You're teaching them how to backboard, or well, not so much backboard anymore, but starting IVs. And then you kind of explain why we would start IVs and we get them started on those concepts. And then as you move up into the learning planes, you start doing application level, and you want them to take the information that they learned in their theory courses and take those skills, and we want to use that information and put them into new situations. And the way we do that is providing them scenarios. And so if you guys are, for example, just teach about narcotic overdose, this is a great case to pull up. And in class, I'll introduce them to the signs and symptoms and the pathology behind a narcotic overdose. And then I'm going to pull up a RealDX case and show them a video so they can start applying that information right away and integrating that information. And RealDX provides you with approximately 700 cases, different sites such as clinics, rural medicine, EMS, ER. And so you guys have a variety to choose from. And then we want them to take that information and we want to transfer that learning from one situation to the next. And so we start giving them simulations in lab, and this all culminates into capstone and internship. While we're giving them the scenarios, we want them to make connections between ideas. So they start taking that information, they not only apply it in scenarios, but they start formulating rule outs. And I think Ian and Nora did a really good job of showing you guys and demonstrating how they did that, even from the beginning of the scenario. And they started formulating and implementing their treatment plan. And as the treatment was rendered, they started analyzing, is that treatment plan working? And this is exactly what we're doing for students in the lab room. And then at the end of your scenario, or at the end of a call, depending on what setting you're coming from, you want that student to start justifying their decisions. And so what I do, and this is an important piece of the education, is we really want the students to self-evaluate. I do this first because I want to be able to identify any holes that they may have, and I want to see if their thinking is actually correct, if I need to redirect them. And then when I start getting my feedback, after they've given their self-evaluation, I want to give them their feedback, and I want to sandwich it. And it's a positive, then a negative, and then the positive. And so I always start off, this is what you did really well during this scenario. This is what went well during the call. And hopefully this kind of feedback is translating into the field. We should all be analyzing our calls after it happens. So we start off with what went well, and then we start talking, okay, this is the holes and gaps you have, or this didn't go well, and we start redirecting the student. And the way I might do this, I always want to redirect them in a positive way, because I want them to be able to achieve goals and look for goals to work toward. So for example, if I have a respiratory scenario that I just gave them, and they were supposed to give epi to that asthma patient, and they didn't, I'm going to tell them, all right, you missed your epi on this call. This is why the patient needs to get it. I want you to go study your respiratory treatment guidelines because you're missing that piece. And then at the end of it, I want to reiterate what I want them to keep. And the reason why I end with that and not with the negative is because if we end with the negative, students will walk away, and not only will they try and change the negative, they'll also change the things that were good. So I always end, I want you to keep these things, I don't want you to change them. And then finally, we hit the create. This is where our wheelhouse as educators. This is where 90% of our effort goes. This is what we work toward. And this is producing newer original work. And this is really to support the student and all of the other learning planes. So RealDX supports you in this by doing the creation work for you, which for me is fantastic, because sometimes I need something quick and I don't have time to create, but I can pull and draw from this resource. And as you guys can see, it's been facilitating our virtual learning, but it's always supported our classroom learning as well. The nice thing about RealDX is that they're learning from experienced providers. So they're working on team dynamics. They're good examples of how a team would work together. These providers also are excellent history takers. They're great investigators. They always ask questions. The students get good examples of what questions to ask and when and what order and when it's important and when it's not. And it also allows them to start witnessing how scene management takes place within a variety of settings. And that's the wonderful thing about EMS, and even having doctors and clinicians be doing these videos, because you can learn from those experts as well. And the hard thing I think that we have that we're always aiming for is therapeutic communication. We give them feedback on this, hopefully in every scenario, and hopefully the internship experience helps build those skills. But at least the students start building or start looking at these experienced providers and see how they communicate with panicked and angry and despondent patients. When I first learned about RealDX, this was probably the most important thing that I was after. I have a very hard time simulating what it actually is like in the field. No matter how many times I painted that pink mannequin white, it just didn't do the same as actually seeing a patient. All of us as experienced providers, we walk into a scene and we have a catalog of visual cues from previous patients that we've run, and those visual cues help us clue in on what's going on with the patient. So if I have a patient who's sitting in the corner and he has a 100-yard stare and he's diaphoretic and he's pale, I'm gonna go, I need to take a blood sugar on this patient, just based on the fact that I've seen this patient 50 other times on 50 other calls. So this is what RealDX starts to do with your students starting in the classroom. it starts building their catalog of visual cues that they can draw from later on. And those visual cues bring actual real world application into the classroom and into your lab rooms. And no matter how many times we get that mannequin out and we can do really good simulations, it's just not the same as all of the team dynamics and all of the dynamics of a scene that get pulled in the real world.